Welcome back. I saw that my friend Derek made a video about The Rock and his steroid allegations on his channel, More Plates, More Dates. And I was intrigued that Derek said that the AI scan, which is not an AI scan, it's a CT scan with dye. They put iodine contrast dye. It goes through your coronaries, which is the arteries in your heart. And it sees if they're blocked or not blocked. It can detect soft plaque, it can detect calcified plaque. But basically, Derek, who I have learned a lot from over the years and who probably misspeaks less than I do, said that the CT scan that The Rock got was probably not affordable for the average person. And very recently, there was a cash pay price in Kansas City of less than $400 for this scan. And then probably $600 extra, $700 extra for the AI portion read of that scan if it's necessary, which often it's not necessary. But back to things that you might find more interesting. The Rock also noted that he had very low HDL, which of course is a very common sign of steroid use. And this is our first time seeing this video. So I guess we're going to see what The Rock says and what Derek says about that.
Yeah, I want to make a prediction. The Rock is probably going to say that he's natural or avoid the question. I don't think he's ever come out and said that he's taken anything. He sort of either said no or played silent, right? And he, everyone sort of knows it's extraordinarily unlikely.
Mm-hmm.
But if you've played this character and denied things for so long, it's hard to weave your way back to, okay, I'm on TRT, but I'm not getting bigger. Mm-hmm. So it'll be interesting to watch and see, especially because Derek did a video on it and he has an entertaining way of putting things together.
And then it came back and, it was almost like, when you hear a song for the first time, you're like, holy fuck, I love that song. That song sounds great. Yeah. So I remember when you told me, you said, hey, look, here's the report from our head cardiologist, who's a very good friend of yours. And you said he said, looks great. It is just an anatomical thing that's happening back there. It's not built up at all. Yeah. His valves look great. Come back in 3 years.
So when you get a scan like this, there's two main ones, clearly and heart flow, and they both have plaque analysis. You shouldn't just tell the patient, this looks great. You should give the patient the report or be looking at it together, ideally, and say, this is your total atheroma volume. This is how much is soft. This is how much is low density, which might be less stable. This is the location. And there is reasons why this AI report, believe it or not, are not accurate.
Yeah. And to piggyback a little bit on the affordability side of it, the way I think of it is, even if you don't run a secondary AI analysis for probably, 80% of people, the CCTA itself is going to tell them everything they need to know as far as management and next steps. You can always get the additional analysis, even if you have a CAD-RAD 0. Nobody's going to stop you from that. But these may cost $700 if you're on the coasts or New York. And if you split that up over 3 years, because I don't see why you would do it more often than that, it's less than $20 a month. So the affordability for the average person, I think, is a matter of priorities. And again, The Rock isn't a healthcare provider or like a biohacker who sort of is fixated on some of the stuff around heart disease. So his terminology is not correct. I don't think they're trying to find valves in his circumflex artery.
No.
But, there may be more to that. And maybe he did have a totally clean and clearly CCTA.
It's possible.
But again, it's unlikely. Any male in his 50s, you're not surprised to see a little bit of plaque that's there.
Yeah. One other note, CT scans, of course, do have radiation. Modern CCTAs, especially with good protocols on good machines, are between 2 and 5 millisieverts for an average sized person. A calcium score for reference is about 1 millisievert, and the iodine that they use is not radioactive. These are all myths that I have heard propagated often on social media.
And what was amazing was, your cholesterol was actually pretty good. I mean, you had low HDL genetically, which is the good cholesterol. It's a little oversimplification, but when we did a deeper panel of your cardiovascular risk factors, and we looked at things like ApoB, which is now being declared as this sort of the best biomarker for your heart, which again, most doctors don't do.
They don't do that.
Most doctors don't do that. Didn't we just write a article in the clinical literature, Journal of American American Journal of Preventive Cardiology. We talked a lot about ApoB and many other risk-enhancing factors. That being said, you have to address the elephant in the room, the steroid use, which is certainly a risk-enhancing factor regardless of your ApoB, which is, of course, ApoB and LDL are very closely correlated. So it's weird that they're talking here and they say ApoB is something that almost nobody checks, but if your LDL is 25, what is your ApoB going to be?
Yeah, it's also going to be low. It's interesting with the steroids. I mean, where do you draw the line between healthy TRT and then what is considered steroids? I mean, you can pick different drugs, different medications. And how much of that risk do you think is the compound and the dose itself versus the amount of size that someone gets? So let's say The Rock got his physique on 500 mgs of test per week versus The Rock got his physique on 5 grams of anabolics per week, right? Obviously, one is more inherently risky, but there's still some risk to being that size.
Yeah, as far as a electrical cardiovascular risk, I would say they're relatively equally weighted. As far as ischemic and congestive heart disease risk, so you think about basically plumbing or structural, then I would say that the overall size of the individual is probably a larger driver of like structural disease, congestive heart disease. Obviously, you can get doses really high and have all of the above happen. But in terms of other organ systems, I think that the dose specifically is a higher risk. So certainly if you're talking about prostate cancer, an extremely high dose of TRT plus or steroid cycle is going to grow that much faster regardless of the size of the individual. And this is different for every organ system, liver, kidney, et cetera.
That was super low.
Interesting that I just noticed. He says HDL was genetically low. It's like, how did you determine that? Like, the guy obviously came to you relatively recently and has been on hormones probably for years. Like, he has low HDL because it's like the number one thing that happens when you take gear that's reflected in biomarkers, with exception of like the crushing of gonadotropins. You will have suppressed HDL. So I thought that was an interesting like caveat. He's like, it's genetic, not just you have low HDL. He probably knows that the androgen use will have that on your.
I guess the head cardiologist forgot to listen to the More Plates, More Dates video before they did the consult.
Skip their recommended reading.
Yeah.
Cop out there, but regardless, interesting. So it's not always going to be something that is incredibly, like, he basically got a second opinion. This guy like totally disagrees with the first guy. It's highly likely that you could have had a third guy come in and say, you know, the first guy was probably right for all we know. Interestingly, though, to me, more so than the HDL thing, is the fact that he is speaking about this anatomical, unique, like structural abnormality that's getting confused for plaque accumulation. If this was something you had done before, like presumably, this is something that would have been noticed because it wouldn't have been changing. If it was an anatomical, like very unique structural thing inherent to your body, this would have been picked up before if he had ever had preventative.
Excellent point. So if you had a RI, ramus intermedius, or myocardial bridge, or other anatomic variants of the heart, a strange bifurcation, whatever the case may be, this would be well known, and you'd be on the lookout for whatever might be downstream to that. And anecdotally, it does seem like many of these variants do accumulate plaque much more often. So is it really that there's no plaque, or is it because that there's some sort of variant, and because of that, the flow is different and the atherosclerosis in that variant artery is different?
Yeah, I don't know. And we haven't watched the entire video. So I don't know if The Rock said he had a scan like this done in the past, or if that's implied here that someone who's proactive with their health probably has.
Good friend of ours, Dr. Samantha, the structural cardiologist. We'll have to have him on the podcast in the future to discuss some of these niche things for people who might be interested, and just explain cardiac imaging or advanced preventive cardiac imaging more specifically. more in the future, because this is kind of a recurring theme. Every time we do a video on it, there's people commenting CCTA bad, radiation, or why don't you do myocardial perfusion imaging, or why not a functional MRI of the heart? So, we're very grateful to Dr. Meyerson and our other co-authors of our lipid paper. So I feel like we've kind of squashed a lot of that. She's a lipidologist that we wrote with. So we will continue to have expert opinions on here. And instead of just complaining and being sarcastic on this, obviously this whole thing has been very sarcastic. But we're not just being mean to people. We're pointing out where very popular people like The Rock may have a gap in their medical knowledge. He's not a medical expert. And we're literally just trying to help people by showing how you can go get this scan that The Rock did for less than $500 in most areas, and how you can actually approach it without the extra fear and myths that you're hearing in places, probably not More Plates, More Dates, but you're hearing them in other places on social media.
Well, and even letting people know that it's more accessible than they might think if they hear people say, oh, it's expensive, it's expensive, it's expensive.
He's suggesting that he's never had screening done, despite the fact that he is the highest paid actor on the planet, I believe. A guy who is one of the highest paid and one of the most who needs to rely on being like a big jacked, probably on hormones guy to be that most paid actor. And yet in his 50s, he had not even had the screening done. Like, it just goes to show, like, a lot of people are always like, oh, these people have the best trainers, and they have the best this, and they have the best that, and they have the best access to this and that. And it's like, oftentimes, despite the fact that they have all this money and all these resources, there's no one in their camp that's like actually properly advising how to be thorough and diligent. And then
This is a great point. And frankly, many people like The Rock, or people in his situation, they would be better off going to Merrick, Derek's clinic, where both of us previously worked and helped develop a lot of the treatment algorithms. I don't believe they do CCTAs there, but they do a great job. Derek is obviously very preventive health focused, and we're obviously very preventive health focused as well. But he's absolutely right. People that you would think would be very famous or have a lot of resources, it's hard for someone that's not in healthcare to discern a high quality care versus, gimmicks and things that are interesting. Just like if I go to a car shop, it's hard for me to tell like what makes a good mechanic. I'm not really sure. I don't know a ton about cars.
Yeah, and you and I have both seen, I'll just say, patients that are in the Hollywood or LA area and have a lot of resources, come over on protocols that, quite frankly, don't make a lot of sense. I have to, ask them, and what was the purpose of this, say, just random slew of peptides, and they don't know. So it doesn't sound like there's a lot of true informed consent that's being gotten. Like, hey, this is the goal of this treatment, and these are the potential downsides. It seems like it's just sort of whatever is popular in a way for, certain peptide doctors to make money.
Yep.
Is what is the flavor of the week. So, I think with personal wellness becoming more and more popular, that people will look into, concierge medicine, or even some platforms like Merrick that offer, connection from consumers to physicians or healthcare providers that, are the cut above the rest, where they know more than just your GP and know more than the peptide only doctor, let's say.
Yeah, at the end of the day, medicine is both a good and a service. And it's important for the consumer to know, is this more of a good? For example, am I just getting a hair loss or sexual health med or GLP-1 or whatever else here? Or is it more of a service that's actually looking out for your health in a way that it is not incentivized to recommend something that's not a huge moneymaker or gimmick? So people will come here, and it's kind of like having a coach or someone who's truly on your team with some sort of intrinsic or extrinsic motivation to have you be as healthy as possible. And if you're interested in a peptide, you should be able to ask your doctor or nurse practitioner, what are the upsides and downsides of this? And it's perfectly fine to say, I'm super interested in taking this. I heard, or I know someone who took it and they felt fantastic. They started to beat my 5K time or my They beat my deadlift PR. So I'm just super interested in doing this. I want to be strong and fast and happy. And what are the downsides of doing this? So I think it's fantastic when patients come in and ask us that. Sometimes people are apologetic when they say that. They preface it and they say, well, don't judge me for this, or I know I probably shouldn't ask, but I'm curious about a GLP-1 because of this, or I know my testosterone's technically normal, or my free testosterone's technically normal, or whatever the case may be, but I'm curious about this hormonal intervention. It's always perfectly fine to ask, even if you ask about PP405, which is in phase 2 clinical trials for hair. This is very random, but it's fine to ask about anything. But you should ask, what is the motivation of the person that's advising me? And do they actually, are they an unbiased reporter?
Yeah, which is going to be difficult if you're in like The Rock's position, right? Where, you can reach out and probably any physician is going to be happy to work with him. And if they happen to own a lot of health-based companies and a media company and can use that for their financial gain, it's hard to know if even that person would be unbiased.
Yeah, definitely not. Anyways, let's watch a little bit more of what Derek has to say and then wrap up.
We know they should be checking this stuff until they're, like quote unquote old enough or whatever. Like the guy has been exposing himself to huge risks, fluctuating body weights, using significant amounts of hormones, probably eating 6,000 to 8,000 calories a day, supposedly, which is absolutely not, going to be healthy for you ultimately. The fact that he had not actually done any sort of like imaging until that point is pretty fucking wild to me. Like there are guys now who are educated and being as careful as possible, getting imaging done as early as like their 20s to make sure that they don't have any predispositions or problems before they actually go down.
Yeah, it's a great point. It's never too early, but the earlier it is, the more downside there is. So I actually haven't gotten my first CCTA, what The Rock is talking about. And I do plan to do so soon, since I am now closer to 40 than 30.
Oh, I thought you were going to say you're going to do it when you hit 260, like The Rock, since you guys are the same height.
Yeah, when I get to the same weight as The Rock and Bradley Martin, I'll do one. No, but in all seriousness, I am going to do that at some point. I have not done a carotid ultrasound, but Derek's right. In general, a rule of thumb is the less healthy you are and the more risk factors you have, the earlier you should do it. I am much taller than the average person, and I also don't have insulin resistance, and I don't think I ever have been insulin resistant. I don't think I've ever had significantly elevated inflammatory markers either. But, I am a male, so at some point I think it makes sense in your late 30s or 40s for every male to consider, should I get a scan of my carotid to look for plaque? Should I get a scan of my heart to look for plaque? If not earlier, like Derek mentioned, anybody who's a bodybuilder or anybody who is enhanced should be thinking about these things in their 20s.
Yeah, depends on your family history too, or if you've been diagnosed with FH. There's a lot of reasons you might push that a bit earlier.
Mm-hmm. Yeah, well, I think that covers it. Hopefully this gave people some good information about what they should do about their heart health and whatnot. I guess we didn't really talk about
I thought
The Rock
this was a
and
steroid podcast.
I thought it was a steroid podcast too. Don't do steroids, kids. That's the point of the podcast. But if you do, then just like if you smoke tobacco, if you drink too much alcohol, then talk to your doctor about it and say, hey, when I was in my 20s, I smoked a lot of tobacco and drank a bunch of alcohol and did a bunch of anabolic steroids. What do I need to do to assess for these risk factors? An adept physician would say, oh, well, you've had 37 pack years of smoking, and we're going to go ahead and do if the appropriate age, then we'll screen for lung cancer. Maybe we'll screen for other cancers too. Maybe they'll be doing Grail Gallery tests. Maybe there'll be more aggressive screening for cervical cancer if it's female. That's just one example. It's the same thing for anabolic steroids. So tell your doctor, and if they're going to judge you and say, well, you should have done them and not help you otherwise, then go find a new doctor.
Yeah. You have to find someone that you can build a good rapport with and trust. And like you said, people would say, like, don't judge me for this, but that's sort of the foundation of the doctor-patient or nurse-patient relationship is it's non-judgmental by definition, or at least it should be. So hopefully we've given people some things to think about. Hopefully this wasn't a click and bait and switch situation. But as always, thank you for your time and thank you for listening. If you made it this far, may God bless you with health and happiness.